Good morning. My name's James Danger, and today I'd like to talk about the burnout, a silent saboteur in IVF laboratories. This is based on a recent publication in the Journal of Assisted Reproduction and Genetics by Doctors Bazar and Najewski, entitled The Burnout, a Silent Saboteur in Vitro Fertilization Laboratories. And here is the URL. It's recommended everyone should read this paper. But before we start, my usual welcome and disclaimer. My name is James Danger, and I am an embryologist with more than 50 years' experience in IVF. These videos are intended both for IVF clinic staff and for IVF clients, and of course for other interested parties. These videos for my Fertility YouTube channel are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice that you receive. Hope it helps. And like all things, nothing exists in a vacuum, and so I'm allocating this page to potential supporters of IVF Daily. I'm only just starting out, but if you would like to promote your company or clinic or product, this may just be the place for you to do that. In supporting Fertility's IVF Daily channel, your support may mean an IVF client becoming a better informed IVF client. You can click subscribe or become a sponsor, or just make a donation to help others on their fertility journey. Leave a comment. Okay. So we're all so happy we have our own day. July 25. As a rule, embryologists are a very happy group of people. They're usually science graduates, often trained specifically in embryology, and they enjoy working in an interdisciplinary team and collaborating with other scientists and working in a form of applied science that gives joy to them but also joy to others. But like all sunny days, there are clouds on the horizon, and the authors of this paper would like to make a couple of key points. Embryologists do operate in a highly demanding environment where burnout is an increasingly recognised occupational hazard. Embryologists report the highest emotional burnout levels amongst the assisted reproductive technology professionals, which include doctors, nurses, ultrasonographers, geneticists, and pathology staff. The contributing factors include excessive workloads, irregular hours, outcome visibility, ethical dilemmas, limited career progression, and poor interdepartmental communication. What that means is if you're working in the lab in the dark and the rest of the clinic is busy upstairs seeing the patients, out of sight, out of mind. Burnout negatively affects the cognitive performance of staff, the psychomotor precision, protocol adherence, and communication, and these directly impact IVF outcomes. Purportedly, high burnout laboratories show increased witness discrepancies and reduced patient satisfaction. Evidence apparently suggests that burnout is not only a personal issue, but also a critical quality and safety concern. Burnout in IVF laboratories is a systemic issue that encompasses embryologists' well-being and ART success. Multi-level interventions spanning organisational policies, regulatory framework, leadership development, and technological innovations are essential in understanding and processing burnout. Integrating burnout assessments into routine quality assurance and staff appraisals and regulatory monitoring can achieve staff sustainability and patient care outcomes in reproductive medicine. Oh, there we go. The paper basically asks 5 questions about burnout: understanding the critical role of embryologists in reproductive medicine, the types and causes of burnout, the impact on IVF outcomes, strategies to mitigate burnout, and other directions. I'll leave that for the paper, but I'd like to make a few comments. Basically, embryologists serve as an essential specialist in reproductive medicine, performing technically demanding procedures that form the foundation of IVF success. It covers all the technical aspects of gamete and embryo handling, many at microscopic level, requiring sustained focus over many hours and without interruption. New technologies have significantly increased the degree of focus and activity and responsibility, specifically pre-implantation genetic diagnosis and cryostorage. But it's more than that. The range of clients have also expanded to include fertility preservation, gamete donation, fertility tourism, PGTA, for non-fertility issues, gender aspects as well, etc. The next big issue, of course, around the corner, which no one's really talking about, is polygenic testing of embryos for specific traits which will make IVF important not just for infertile couples, but for the whole reproducing generations. But embryologists are individuals and they feel their responsibility. It's often said that IVF is a personal journey that involves the action of many. Each procedure is also a personal intervention for each embryologist. So, as the authors point out, the work of embryologists directly impacts patients' reproductive potential and family building goals. This creates substantial psychological pressure, as embryologists are acutely aware that their performance influences not only the pregnancy rates and the clinical well-being, but also the emotional and financial well-being of patients. When you see an article headline like "A mix-up," it causes fear and terror in all aspects of the clinic, but also in every embryologist. There's a huge responsibility to bear. So the causes of burnout, the author suggests, can include excessive workload and time pressures, extended working hours and 7-day rosters, chaotic scheduling due to clinical and client needs, and understanding resource constraints. Just coming back to the chaotic scheduling, IVF is essentially a medical procedure, and therefore all the events need to be scheduled around the clinical timetabling of the clinics and the theatres and the clients. And so, for instance, if a client is booked in at 10 o'clock for an embryo transfer, the scientists have to thaw that embryo in the morning and have all the checks done and the validation done so that when the patient arrives at the 10 o'clock meeting, it is all finished. These add enormous pressures on staff, which you don't get in many other laboratories. But there are staffing and workplace dynamic issues where different teams are involved in clinic care. For instance, particularly doctors, scientists, and nurses. They're the three areas, groups, and the communication between that is often a critical thing. It's very difficult to manage. There is also a stratified career development. That is, once you're trained as an embryologist, there is not a great pathway going forward unless you get into management. There are huge emotional and legal overtones sitting on the shoulders of every embryologist all the time, and there's a changing ethical complexities and moral distress in dealing with patients. So including dealing with gay and lesbian couples, single women, poor communication, fertility tourism. It makes it very hard often to deal with all those patients. Also, IVF is a highly technological and regulated industry. Each area has their own regulatory bodies and society-based groups that are producing guidelines and recommendations which clinics have to follow. It's also highly managed in terms of regular inspections, audits, and quality management systems that people are trying to implement. But the real concern is the privatisation and amalgamation of clinics, turning the business from a cottage industry to a highly profit-driven industry. This is where the greatest level of burnouts have been experienced. There is also changing expectations of clients as they delay having childbirth till later in their life, and there's more increasing urgency in success. Of course, one solution to this is to automate it. And already in IVF, there are, for instance, time-lapse incubators that have been developed to minimise embryo handling. These do protect the embryo over the 4 or 5 days of culture, but it does create huge amounts of data to process, and often it's the time required to do that. It's far more than just processing the embryo itself. And increasingly, clinics are using artificial intelligence to predict the best embryo, which in itself is creating an enormous pressure on embryologists to try and meet the expectations of artificial intelligence. There are also the first reports of robotics being developed for many critical procedures in IVF, including fertilization, embryo handling, egg collection, and vitrification. But the increasing use of AI to manage and predict outcomes will ultimately lead to loss of control and career uncertainty. So you might like to ask the question, do we still need embryologists? Well, you only have to look at this graph, which looks at the number of babies born since when I first started in 1978. Actually, I started in 1977. And you can see this huge exponential rise, and there is no suggestion at all that we are reaching a peak. As couples delay their time for childhood and new technologies being developed, the rise in the babies born through IVF technology will, I think, continue to rise exponentially for a long time. But in the paper, Do We Still Need Embryologists?, the authors make the following comments. In IVF, relevant examples of novel equipment that can automate and automatically perform embryo assessments, patient identification, vitrification, and sperm manipulation, selection, and analysis are already on the horizon. This has questioned the role of embryologists. However, the introduction of novel technology is not straightforward. It generates numerous challenges, including which manual interventions should be automated and why. Do machines perform better than humans? And does automation involve higher treatment costs? You may be able to automate the production line for a Tesla electric vehicle, but automating the IVF process orders a degree higher. But the authors go on to say at the same time, certain intellectual activities such as the integration of novel categories of data and their interpretation, formulation of novel key performance indicators, generation of novel education and training content, and enhancement and collaborative research remain human prerogatives. Therefore, while it is to be expected that some direct human intervention will be partly replaced by automated devices, we can envisage that the embryologist's role will not become extinct, but will evolve in new forms. Ideally, this change should be guided by principles safeguarding the ethics of medicine and human activity. But just remember, 95% of the work the embryologists do is in the lab bench. So just to finish this video, work pressure and burnout is recommended. Everyone should read the paper, but we need to summarize by saying the demand for IVF is increasing, not just for infertility. 43,000 more embryologists, 4,000 new labs in the next 10 years. Where are those embryologists going to come from? And what will their skills be like? And how will they maintain their skills? And what pressures will be on them to deliver increasingly higher rates of pregnancy? So not only is demand for increasing, not just infertility, but it's changing because of the way couples are making decisions about when they have a family. And there will definitely be increasing demand for IVF technology outside of IVF. So as a last statement, I need to say that as a client, you should be aware that the embryology staff are under increasing levels of pressure and risk of burnout, and that may have the impact on your outcome. And you should be asking your clinic about staff health, workloads, and staff turnover. So I'd like to thank you for the video. As I said, IVF is a personal journey that involves the actions of many. It helps to understand all the aspects of that journey, and I hope this video helps. If you like the information provided, please tell others and maybe subscribe. Thank you.